Good evening. My name is Erasmus Okello. I'm an assistant lecturer in the Department of Anesthesia. And by training, I'm not one of those who have been antagonizing each other. When they argue and they stop, I take off. So, by training, I'm an anesthesiologist. I have a subspecialty training in critical care, and I currently work as an assistant lecturer in the department and also with Mulago ICU. Today I'll just be sharing with you quick things about critical care management of DKA, and a lot that has been discussed already by my seniors, my former teachers, and my colleagues now applies, but I'll be putting a little bit of the oomph of ICU to it. So I have no disclosures to make or that I'm willing to declare, but we move on. So the menu here is, I have no other cities to show, I have no trials to display. We do individualized care in ICU. Everybody matters, we have time for you. And unlike everyone who has been complaining, at least relative to internal medicine and pediatrics, we have relatively more resources to actually. They may not be world class, but basically we have a chance to do medicine-based evidence rather than what you call evidence-based medicine. So DKA, as already defined, basically the hallmark here is high gap metabolic acidosis. The rest just follows, but it's really an acid-based problem where you have a high gap and organic acid produced within the cells, and the hydrogen ions be buffered within the organic acid being pushed out and disturbing the acid-based environment outside. The diagnostics, I won't talk about them, it's been discussed already. I have only 7 minutes. So the big problems in DKA, you have acidosis, you have ketonemia or ketogenesis, you have glycemia. It may be hyper, it may be euglycemia. In fact, you might have hypoglycemia, okay? Depending on where the patient has been, what the patient takes. Lately, even now, environment, I'm seeing a few patients who are on certain class of drugs called SGLT2 inhibitors. They actually induce an euglycemic, diabetic, ketotic state. So we have these patients, so don't just wait for the sugar. Fluid and hemodynamic embarrassment is a big thing, and we really focus on that because sometimes just fixing that alone can actually pull the patient out. And then the underlying triggers has been stressed already. I might mention a few things, but let's carry on. Background chronic complications, diabetes, perhaps in the pediatric population, every now and again, it might be the first presentation, okay, as DKA, but actually in many people, they've been going around circles, treating it as malaria and so on, and getting end organ dysfunction. So there's some background dysfunction, which may be subclinical or even apparent already, especially target organs. Think about vessels, endothelial damage, think about immunity, think about renal, think about ocular and so on. Those may be subclinical, and these patients present with this. So while you are thinking about managing DKA, resolving the acid-based problem, think about that background issue, because a patient has to go back home, and we do holistic care. All right? So why do patients get admitted? DKA, honestly, is an emergency room disease. You come to emergency room, you get treated from there, we resolve the gap, we transition you into long-term care and send to the general ward where the internist or the pediatrician will continue care. So, generally these patients seldom make it to the ICU in a good center. So why do we get DKA patients now in ICUs? Number one, misdiagnosis. Someone is treating malaria. Someone was thinking about this patient having that acute abdominal pain being DKA. Okay? So the patient is not getting better despite the interventions they're doing. Like, okay, you know what? This patient is too complex. Send to the Kafurus. So they send him to the ICU. Under treatment in the general flow is a big thing. Because, like my colleagues already stressed, the resources are limited. You need one-to-one, you need a lot of round-the-clock monitoring of this patient. Now, if you're in a ward with one nurse who's taking care of 110, whatever number of patients, how long will it take for us to attempt the basic things this patient needs to come out of the DKA? So sometimes it actually goes on spiraling until they are worse off. Failure to diagnose the underlying trigger. Dr. Nambuya did a very good job in stressing out occult infection. It is something that's under-recognized, okay? It's under-recognized, and if you don't pay attention to it, or at least suspect it, you might miss it, and then the patient will not pull out. Dramatic respiratory presentation. Of course, ICU has got machines which can help you breathe. So when someone is breathing so fast, everyone's like, respiratory distress, ICU, okay? I'll talk about that in a bit. Surgical patients are notoriously sent to ICU because a patient has got a big abscess in his leg, but the surgeon says, no, it's acidotic, first fix that. You will not resolve the acidosis as long as there is an abscess in there. So, as an anesthesiologist as well, we are trained to actually help you go through surgery with your DKA, because we know getting you through surgery actually helps cure the DKA. So this is damage control, resuscitation, damage control surgery. This applies even for congenital diabetes, because what triggered the DKA in the first place? It's an infection, it's a big abscess in your leg. How will I resolve it when it's still there? So it's actually a balance. So do resuscitation, think about getting out the infection, and actually get the patient back and complete treatment. If you don't, you won't get out of it. And it's common. They end up in the ICU. And we open the wound. We open the abscess. Sometimes. Declining clinical status is a very genuine reason. A patient who's severe acidemic or is getting complete treatment of the DKA will probably present with altered mentation, might be having worsening acid-base status, ventilated drive, which is necessary to compensate for the acid-base embarrassment, might be getting worse as well. Next slide, please. Now, diagnosis has been talked about already. I just put four bullets there. Remember, you have to make a general assessment of the clinical status of the patient, because when you save them from whatever is killing them, you have enough time to identify the problem and fix it for good. Specific diagnosis for DKA and related differentials. There are a number of tests that have been discussed already. Remember, you don't diagnose DKA, but the number of differentials must also evaluate for, because they're very important. Then you also look for specific assessment for possible triggers. Dr. Nakota told us about looking for things like cardiac enzymes, looking at an ECG, sometimes the patient might have had a stroke, okay, and that may be the trigger. Someone might be having big abscess sitting somewhere. Look out for that. Specific assessment for complications of the disease. Again, you don't want to just finish resolving the DKA and the patient goes back home saying that doctor was good. Then they come back home. You want to look for the complications and set a plan going to actually make sure they never come up with an issue. So, what's our approach? Just a nutshell quickly. Airway breathing saturation. Somebody say, do not ever forget glucose. A, B, C, D, E, F, G. Do not ever forget glucose. Okay? But acid-base, electrolyte, insulin therapy, explore and fix the underlying problems and initiate long-term issues. Long-term planning. Okay? So, airway. You want to send them to us, the patient has respiratory embarrassment. Please, needs to be ventilated. Kindly hold your horses on intubating those patients. Reason? The acid-based problem they have is a ketoacidosis. They have got a non-volatile acid in their body that won't come out. How do they compensate for it? They have to breathe so hard to blow out carbon dioxide. Now, the minute ventilation you need to keep your CO2 down to compensate is so huge for our machines to keep up with. If I keep up with that with a machine, I damage your lungs and you die. Okay? And I don't want you to die. So we try to stay away. As long as you are awake enough, you're able to control your airway and you have a respiratory drive, breathe. If you're getting weak and you still can't control your airway, we can't try to put in a mask on your face and give you pressure to support you. High pressures, but non-invasively. It's called non-invasive. Now, people who get intubated are those who might have a compromised airway already. Like someone is unconscious. They can't protect their airway. All secretions are going down there. Now, I know in that case, they will have another problem which will keep driving this. They'll be intubated. Somebody has got declined respiratory effort and the CO2 begin to rise. There I have to help them out because I know the risk, the benefit outweighs the risk in this situation. Okay? All right. So saturation is a priority. Most important thing is recognize, classify, and treat the hemodynamic status. These patients don't just come with volume depletion alone. They might come with a cardiogenic picture. Okay? Being so stressed out by the acid can stun your myocardium and it's just flabby and useless. It needs inotropic support. The acid issue, yes, initially to compensate, you might end up vasoconstricting and so on, but as it goes on for a long time, the vessels give up. Okay, they go into a point of metabolic uncoupling and they vasodilate. So these people can come in vasodilatory shock. Okay, so classify, kindly move on, let's go faster. Okay, so volume status, remember, there's total body water. Then there is relative intravascular volume compromise. Dehydration and hypovolemia are related, but they may be different. Dehydration chiefly, by definition, means you are hypernatremic. Okay, meaning you've lost free water. Hypovolemia means you have lost blood volume, you intravascularly deplete. Now, most of the diabetic patients have both. Most of them, when they present extremis, they have lost a lot of water, they're hypovolemic as well. And they may present in hypovolemic shock. They need volume resuscitation. Now, they may present in vasoplegia, I mentioned that already, or they might present in cardiogenic shock. And I told you about so many things. Some of them may be because of the DKA itself. Many, though, are because of the underlying trigger for the DKA. They are an MI. But you're happy running around for the post-small breathing and so on. But the patient has an MI, actually diagnosed and taken for PCI, okay? Or it could be unmasking. It could be unmasking an underlying compensated cardiogenic state. This patient is NYHA stage 3. But now because of the demands to breathe and survive from this DKA, their heart can compensate. So now they go into heart failure, okay? Yeah. All right, so approach to resuscitation. There are so many guides in the books, and some of them are very good for the general ward. If you're individualizing, you have to have endpoints. What is the endpoint for your resuscitation? What's the trigger for it? First, in these patients, you want to restitute intravascular volume. So, a targeted approach, restore them out of shock. So, bolus fluids. So we call that the resuscitation stage. When they're out of that shock, you now want to balance, to optimize them so that they don't slide back. That's the question you ask yourself. Are they getting completion of what I've given? Do I need to give more fluid and so on? And if they get past that, you go to stabilization stage. Yeah. And then you have to get the fluid out. Many times we overshoot. Our patients end up being Michelin babies. They are so swollen. Okay? So you have to get that fluid out. Otherwise they won't heal. Alright? Move on. The anionic acidosis is the sole reason as to use insulin for DKA. Your target is to resolve the gap. It's not to close out the hyperglycemia. So, but remember, the hyperglycemia in DKA may not necessarily be purely from ketosis. Because of the stress the patient is going through, their lactate may spiral. Because of the underlying reason as well they went to DKA, they might be having other underlying metabolic issues. They might be having intoxication, cocaine abuse and so on may be an issue. So think about that. Also, like I said, there's end organ dysfunction already. They might have renal tubular acidosis from underlying kidney disease. So think about that when you're talking about this. Bicarbonate therapy, Dr. Klein mentioned it, and honestly, it's a controversial topic. It's not research-based, it is emotional-based, but at the end of the day, we make a consensus decision and agree to have it in the guidelines. Because we fear to have a patient a pH of 6.9, we fear the number. But the truth is, if it's a purely ketoacidosis, giving bicarbonate is going to make things worse physiologically. It doesn't fit. Reason, CO2 will trigger more lactic acidosis in the body. Okay, dialysis flow has a role. Let's move on. Electrolytes have been talked about already, but remember, especially potassium, the number does not correlate with total body potassium. These people are mostly potassium deplete. Okay, they have just shunted out potassium, and the potassium serum concentration does not correlate linearly with the total deficit. So just giving 40 millimoles and getting a number within 4 hours of 4 point something doesn't mean you've corrected potassium. Long-term potassium correction has to be in the plan. Okay. Thiamine is very important and we miss it. It's part of the refeeding syndrome we're induced by giving insulin. Insulin will shift everything, including factors necessary for keeping a patient producing ATP. Thiamine is one of them. Pantothenic acid, we in ICU put all our patients on multivitamins. As for the evidence, okay? At least medicine-based evidence. Okay, please. All right, please carry on. Next slide, please. Okay, monitoring okay, carry on. All right, I thought this would be good for the medical students. You like mnemonics, okay? There are 5 eyes, or you can say 6 eyes for the triggers, okay? The patient might have an infection, always suspect that. The patient might have an infarction. The patient might be having inflammation, which may be pre-existing, or they are unmasking it. They might be intoxicated. In some that is driving it. They might be an idiot. I hope there are no diabetics here. You tell them everything and they choose not to take their drug. Or you tell them you're supposed to go not, and they go and actually do that. Non-adherence is a big thing there. And insulin failure, in the Western world, we now have people who have implanted pumps on their bodies, and that could fail. Okay? I think I'm about coming to the end. Alright. Okay. How do we transition? In ICU, we run our insulin as an infusion. Okay. We run insulin as an infusion. When the gap has closed, that's our marker. We're not looking for ketosis, ketos to disappear. When the anion gap has closed, that's when we say we are done correcting DKA. Then we put the patient on basal infusion. Just a small dose, maybe 2 units for an adult, to just prevent them rebounding. And then when they are feeling well, we now introduce a subcutaneous long-acting insulin and plan for operation to the ward. Okay? In terms of fluids, there is actually rising evidence that use of normal salmonella, because people require a lot of fluid, they end up with hyperchloremic acidosis. So they just happened. And their resolution of the bicarb deficit and coming to acidosis doesn't happen fast enough. So they resolve the gap, but they go into non-gap acidosis. So there are a number of trials now using balanced solutions, plasma light, and so on. Even ring acid can be tried. There's a lot of literature. Thank you.